today we will be discussing about delirium, which is another important topic. We see most of the patients reaching the terminal stage facing this symptom, and this is a very distressing symptom for the family, if not for the patient. Many a times patients are aware of the delirium once they are out of it, or when someone is your dear one is passing away, patients caregivers don't want to see them in agitation, yelling and screaming, or having a lot of irrelevant talk. So this is one symptom that caregivers find difficult to comprehend, and if uncontrolled they find it difficult to forget it once the patient passes away. So it's very important to learn and to understand a little bit about delirium and how to manage it without using restraints. Many a times we can see in many hospitals people are using physical restraints for controlling delirious patient. That's we manage it mostly in a very conservative way and including the patient and the family. So today we have Dr. Megha. She's a senior consultant in pain and palliative medicine in Max Super Specialty Hospital, Vaishali. She's a trained anesthetist and she's also done her post graduation in palliative medicine from Cardiff University, UK. She's a reviewer for IJPC. IJPC is the journal for Indian Association of Palliative Care, and she was involved in developing curriculum for the undergraduate medical education, integrating palliative care. And she has presented in many international conferences and have publications in many international journals. She focuses mostly on cancer, pain, palliative, and end of life care, and she's involved in many teaching sessions with the IAPC also. They from their institution they arrange periodic sessions on many interesting topics. Sripriya, was Megha able to join us?
Ma'am, I'm checking on that. Like she is still facing some technical glitch. I believe she'll be joining.
Just give us a moment. Yes, Megha, you are audible. Thank you for joining us. We introduced you already. So
No problems. Thank you so much for inviting me. And I'm so sorry. Actually, I'm at my hospital. So thoda sa network issue aa gaya. So just took me some time to join in. Yeah, I'll just share my screen now. Okay, so while it is being loaded, I'm Dr. Megha. I am a consultant here in pain and palliative medicine in Max Hospital, Vaishali. And it's always a pleasure to be amongst, to take such sessions with Pallium. And since we are closely related to them, and to share our thoughts with the esteemed doctors, who are taking out time to do and understand, to attend such lectures, who are doing this fellowship with them. And my slides are still loading. Yeah, there we have. Give me a second. Thanks. Okay. So I hope, Dr. Sridevi, I think you have introduced the topic, yes?
yes, I did, and I introduced you also.
Thank you. Sorry, I joined in late. Okay. All right. So today we'll discuss about delirium, right? A very important topic, and it's not just in palliative care. It is also it's actually a neuropsychiatric symptom. Okay, so more than in palliative care, we also see patients in delirium in psychiatry, and patients who come to neurologists. They also see a lot of delirium patients, right? So delirium, the word comes from a Latin word which means to go out of the furrow, to go off the track, right? The patients who are not really on the track. So there are a few scenarios here. 55-year-old male chronic alcoholic in liver failure who's admitted with hematemesis. In the ward, he shouts and abuses and becomes restless. He pulls out his IV lines. So delirium. 60-year-old known diabetic on insulin found in a state of lethargy. 40-year-old female with carcinoma breast who has had surgery, chemo, and is on one fine morning, she was found in a state of disorientation. She says there are lots of lions in the room staring at her. So it is a neuropsychiatric symptom, right? So what is consciousness, right? So consciousness is, it has three components majorly. First is awakeness, right? So you're all awake while you're, so we have around 42 people with us. So all of you, I'm sure, are awake. However, some of you, or probably most of you, I'm hoping for that. Most of you are alert and are listening to what I'm saying. And some of you may even be aware, you are alert and listening, but also aware and understanding what I am saying, right? So these three are the components for consciousness. Then there's another thing, which is cognition. The internal structures and the processes that are involved in acquisition and use of knowledge, including sensation, perception, attention, learning, memory, language, thinking, and reasoning. So all of this comprises cognition, right? So there is consciousness and there is cognition. These two are important terms when we are understanding delirium. So delirium is characterized. There are four important things when we describe delirium. First is, it is an acute change. It's an acute change, right? Acute change in cognition and a disturbance in consciousness. It's an acute change, one. Second, disturbance in cognition and consciousness, right? And third, consciousness, cognition, three. And fourth is that there is always an underlying medical condition. Just give me a second. There's somebody at the door, is it? Okay. Get it. Resulting from an underlying medical condition or medication or drug withdrawal, right? So there is always a cause underlying this acute state, right? So approximately 20% of the cancer patients may have delirium. 80% of the cancer patients may have delirium near death. So delirium is mostly, for us, it's a poor prognosis indicator, especially towards end of life, right? But does it only happen in cancer patients? As we already said, no, it's not just in cancer patients. And 10 to 20% of all the hospitalized adults, they do develop delirium. 30 to 40% of elderly hospitalized patients, they develop delirium. And 80% of the ICU patients develop delirium, which they call as ICU psychosis, and many other names are given to such delirium. So 80% of ICU patients develop delirium. So as per the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, which is the latest one, DSM-5, there are again yehi criteria. There are four things to remember in delirium, right? First is disturbance in attention, that is reduced ability to direct, focus, sustain, or shift attention and awareness. A disturbance in attention and awareness, reduced orientation to the environment. Second is that it is acute, it develops over a short period of time, and it represents a change from baseline attention and awareness that, like 2 days back, patient was well oriented, attentive, and was able to communicate in a more coherent way. And however, it overlasts only 2 days or a short span of time, it can, the patients have changed, and it can even vary from between day and night, right? It tends to fluctuate in intensity during the course of the day also. The third point is an additional disturbance in cognition, right? So consciousness was the first, second was acute, third is cognition, that is memory deficit, disorientation, language, visual, spatial ability, and perception. And fourth is that disturbances in criteria 1 and 2 are not better explained by any other pre-existing, established, or evolving neurocognitive disorder, and do not occur in the context of severely reduced level of arousal, such as coma. So पहले से like जो patients they are known schizophrenic or patients who are demented, dementia. So all those patients will not come under delirium, right? They are, but they are close differential diagnosis of delirium. And the fifth is that there is evidence from the history, physical examination, or lab findings that the disturbance is that there is a cause to it. The fourth thing that I said earlier, there is always an underlying cause to it. That it is because of, as a consequence of another medical condition, substance intoxication or withdrawal. That is because of drug abuse or to a medication or exposure to a toxin. Will come to various etiologies also. Right. Then there are types of clinical presentations of delirium. Give me a second, please. Let me just put it on silent. Sorry. So there are three types of clinical presentations for delirium. One can be hyperactive, another is hypoactive, another is mixed, right? So hyperactive is the patients present with psychomotor agitation, very common kind of जो हम clinically देखते हैं. बहुत common hyperactive delirium होता है, increased arousal and delusions, and degree of cognitive impairment may be variable or even minimal. Then there is hypoactive delirium. Hypoactive delirium is also very common. However, many times this is under recognized. We do not, when the patient is hypoactive, we may not be able to, get to know. Many times they are kind of, we think they are depressed and they are not speaking. So there can be features of hypoactive delirium, which include withdrawal, lethargy, reduced arousal, which are very similar to that, especially in when we talk of cancer patients. So that the patients, they become weaker, they have generalized fatigability, weakness, so they become hypoactive overall. But that is also one part, which is hypoactive delirium. Then there is mixed delirium, that the presentation may have features of both hyper and hypoactive, which is not unusual, right? So many times delirium is unrecognized or misdiagnosed and mistaken for other close DDs, which are dementia, depression, mania, an acute schizophrenic reaction, or just as a part of old age. But there are certain distinguishing characteristics of all these close DDs. So when we talk of delirium, we said that there is fluctuating level of consciousness with decreased attention. There can be disorientation, visual hallucination, agitation, apathy, withdrawal, impairment in memory, attention. Then it is acute onset, and mostly they have an underlying medical condition which might be correctable. However, when we see dementia patients, there is always memory impairment. There can be associated disorientation and agitation to it, but memory impairment is one very important aspect to dementia. And it is chronic, slow onset, progressive, right? So dementia is not really that the last day patient remembered everything and next day he doesn't, right? So it's a chronic, slow onset disease problem, right? So yeah. So then there's depression, which is sadness. Depression, there is sadness, there's loss of interest, which is anhedonia, and pleasure in usual activities. That is loss of interest in the activities which the patient found pleasurable earlier. There's also disturbance of sleep, appetite, concentration, and energy. And there is feeling of hopelessness, worthlessness, thoughts of suicidal thoughts and attempts, and single episodes or recurrent episodes. This can also be chronic. And there are psychotic disorders where there is deficits in reality testing. Usually they're again slow onset with prodrome, and they are also chronic with acute exacerbations. Implications of delirium. Delirium is overall a very distressing symptom, not just for the patient, for the family, and for the staff, right? Because when it happens in the patient, we are not able to communicate with the patient. right? The time is lost. There are increased investigations, of course, you know, when the patient becomes delirious in as an acute phase. So they undergo a lot of blood tests, CT scans and all. So because first thing is to rule out any organic thing, right? If the patient has suddenly developed this, so in cancer patients, it can be brain metastasis or, you know, meningitis. There can be many things that we need to rule out. And increased interventions, of course, IV line and changes, opioid changes, sedation. So because of delirium, patients do have, they have, it has a very important impact on the patient. And it, of course, prevents patients' participation in the treatment decisions, you know, when they are not exactly coherent and they're not able to express themselves. It also makes assessment of other symptoms more difficult and interferes with the communication between patients and their family. Families, they find changes in the relatives' mental status as a very distressing part. You know, when the patients are not able to communicate, they do not behave themselves, it's very distressing for the families. They also, it increases, you know, conflict with the relatives and increased stress overall. Then, which patients develop delirium? There are certain risk factors. Older age, as we also saw that, you know, 10 to 20% in is the incidence of delirium in overall hospitalized patients. However, it is double, that is 30 to 40% in elderly age group. So older age, male sex, hypoxia, dehydration, cachexia, opioid use, anticholinergic burden, and ECOG performance status. Right. Then there are, so these are the risk factors. These are all risk factors. Then we have precipitating factors for delirium, which is change in environment. So if many times we have, when we are practicing palliative medicine, you know, patients are well oriented when they're at home. However, as soon as there is a change in environment, when they come to hospital or from ward to ICU, there this precipitates delirium. Then unfamiliar stimuli, if the nurse is not telling and she starts pricking the patient, so that's again a precipitating factor. Too hot an environment, too cold an environment, wet bed, creases in the sheet. So, these are the precipitating factors, and what are the exact causes? So there is a fecal impaction. A simple thing like fecal impaction can cause the patient to become delirious, right? Pain, urinary retention, infections, dehydration, brain tumors, hypercalcemia, hyponatremia, which is very common, hypercalcemia in malignancies, and hyponatremia. So drug-induced, it can, opioids, drugs may opioids, corticosteroids, anticholinergics, chemotherapeutic agents like cisplatin, 5-FU methotrexate, withdrawal state in chronic alcoholics, alcohol, nicotine, psychotropic drugs, even thiamine deficiency can cause delirium. So delirium is frequently underdiagnosed due to, you know, formally we are not able to screen for it, right? So we have certain delirium assessment tools, and which are simple. Actually, we may not, you know, for example, me in my clinical practice, I do not really do these examinations on a daily basis. However, most of the questions that are there in these scales, so these, but by default, whenever we go on rounds, we ask these questions, and we are able to have a fair idea about the state of that the patient is in. So we'll discuss a little bit about these. Mini mental state examination, I'm sure you know, we are all aware of this. I'm not sure how many of us do it regularly. So there are a total 30 points. There is time orientation, place orientation, registration of 3 words, and then there is attention and calculation, recall of the 3 words, name the objects, then repetition, comprehension, reading, writing a sentence, drawing. So all these we give marks, and out of 30 for the patient, right? So this is a small example of MMSE, and where if the score is 0 to 17, there is severe cognitive impairment. 18 to 23, there is mild cognitive impairment, and 24 to 30, there is no cognitive impairment. Okay, so like in place orientation and time orientation. These are the questions that we ask. The registration, attention, calculation. This is a small MMSE that we usually do that, isn't it? Whenever we go for rounds, we always ask आपका नाम क्या है, आप समझ पा रहे हैं, आप कहाँ पर हैं अभी, समय क्या हो रहा है. So in one way or the other, we are able to, whenever we talk to the patients, we are able to guess a little bit about it. We may not do it regularly. Then there is memorial delirium assessment scale. This is also very similar. The questions or the content is very similar. Item 1 is reduced level of consciousness or awareness. Rate the patient's current awareness of and interaction with the environment, interviewer and other people or objects in the room. So describe. So what you can ask is describe the surroundings, right? How the patient is able. So इसमें सभी points के लिए, सभी items के लिए 0 to 3 score है, right? 0 is none. Patient that is patient is fully aware. 1 is mild. Thoda patient is unaware of some elements and or not spontaneously interacting with the interviewer. However, becomes fully aware and appropriately interactive when prodded strongly. Interview is prolonged but not seriously disrupted. So the so similarly, ऐसे 0, 1, 2, 3 ऐसे score हर item को करेंगे, है ना? So ultimately, we have to remember 4 points in delirium: cognition, consciousness, acute onset and an underlying cause. Okay, so these 4 important points सारे चीजें इसी पे related हैं. Now then item 2 is disorientation. So 10 orientation items. 10 orientation items are just the same जो हम MMSC में हमने 10 देखे थे. Place and time orientation. Date, month, day, year, season, floor, name of the hospital, city, state and country. जितना patient बता पाता है, 0 means none. 9 to 10 items ठीक बताता है. 1 mild, that is the patient is able to tell 7 to 8 items correct. 5 to 6 2, and more less than 4, less than equal to 4 3. Then item 3 is short-term memory impairment, that is repetition and delayed recall of 3 words. Immediately repeat and recall words after 5 minutes. While we are interviewing the patient, we do that, tell them around 3 words and then later ask them again after 5 minutes. Again 0 1 2 3. Then impaired digit span. This is again, to repeat 3 4 and then 5 digits forwards. So something like that, and then 3 and then 4 backwards, like 100, 97, 94, 91, like that. So 0, if patient can do at least 5 numbers forward and 4 backwards, can do 5 numbers forward, 3 backwards. So 0 1 2 3. Then reduced ability to maintain and shift attention. Again, this is not really that we are doing it. While we are interviewing the patient, this comes as a byproduct of observations. Then that the questions need to be rephrased. Questions need to be repeated when we are asking the patient. Patient's attention wanders, and then patients sometimes lose the track of what is happening. They're distracted quickly by the stimulus. If outside the nurse is knocking or the nurse is some other patient is crying, so they are quickly distracted. So this we observe. 0 1 2 3 again. Then there is disorganized thinking. There's rambling. The patient rambles while he's speaking, sometimes talking relevant and then talks irrelevant, incoherent speech. So describe, or you can ask the patient to describe their medical condition. And 0 1 2 3. So item 7 is perceptual disturbances like misperceptions, illusions, hallucinations, inappropriate behavior. So again, we are observing these. 0 1 2 3. Delusions, inappropriate behavior during interview or which is admitted by the patient. 0 1 2 3. Decreased or increased psychomotor activity, hypoactive, hyperactive, or elements of both are present. 0 1 2 3. And sleep-wake cycle disturbance, disorder or arousal. Nurses, family, patient, and they can tell you about if there is a sleep-wake cycle disturbance. 0 1 2 3. Total, there are total the score is 33 into 10, 10 items, and maximum score is 3. So 13 out of 30 is the cutoff, right? How to do it? So it's basically इसमें orientation in time, place, and person, short-term memory, digit span, hallucinations, illusions, delusions, hypo and hyperactive, sleep, and then simultaneously while we are conducting the interview, we observe for the level of consciousness, disorganized thinking, if the patient is able to focus, sustain, or shift, the attention keeps shifting. So now over to management. Correct the correctable. It is always there, isn't it? For any symptom that is there. Excuse me. So correct the correctable. Then there are non-drug treatments to it. Then there are drug treatments to it. सबसे पहले find the cause. Basic causes: fecal impaction, pain, urinary retention, infection, dehydration, brain tumors. So अगर ये सब causes है जो ठीक कर सकते हैं, correct them. Brain tumors identifying is very important. If there's hypercalcemia, hyponatremia, so sending an electrolyte profile for a patient who has become acutely delirious, very important. Reviewing the drug charts, seeing if the patient is on opioids, steroids, anticholinergic agents. Many of the medications that we use in palliative medicine are anticholinergic, isn't it? Antineuropathic agents are, so these are all anticholinergic agents. They have these side effects. But review the charts of the patient, review the last chemotherapy received. Then if the ask the history about if the patient is in withdrawal state of alcohol, any psychotropic drugs, or nicotine. Non-drug management is so important. I cannot overemphasize the importance of non-drug management in a patient who is delirious. Because there's something called orientation protocol, right? So all the ICUs, ideally all the ICU nurses should be well trained in orientation protocol, not just ICU nurses, all the nurses, because that's very important when the patients who are sick and at, there are higher chances of electrolyte disturbances and those things. So that the nurses should always be able to orient the patient, because the doctors, when we go twice a day on rounds, isn't it? However, the nurses to them for fluids, medications, to connect or disconnect. So always telling the patient and telling the patient about what time is it, it is afternoon, please have your lunch, and those things. Orientation protocol is very important by the nurses and the family caregivers, very important. And importantly, tell the patient and the family that delirium is not madness, isn't it? The family members, they think that the patient has become mad now and what is happening to him. So telling them that it's not madness, continue to treat the patient with courtesy and respect. Even if we think that the patient does not understand, always tell them before you are trying to examine them, or you are giving them any medication, you are connecting them, as simple as connecting an IV fluid. Tell them that we are connecting it, right? So that helps decrease their anxiety, because anxiety adds on to delirium and makes the patient more hyperactive. So treat them with courtesy and respect. No restraints, no physical restraints, ever. There can be no reason that the patient is physically restrained. We have medical restraints available. We have many medications available, and find the cause and treat the cause of restlessness. Patient should be allowed to walk, but accompanied. Yes. Patients should be allowed to walk around. Explain every procedure and event in detail. Presence of family member or close friend. It's very important. Do not take the patient in isolation. If you have to examine the patient or interview the patient, always let the patient be accompanied by a family member. Doctor can acknowledge the patient's distress, कि yes, मैं समझ सकती हूँ कि आप अभी बहुत परेशानी में हो, आप अभी समझ नहीं पा रहे हो, but मैं समझ रही हूँ कि आपको ये परेशानी है और हम देख रहे हैं कि हम आपको कैसे इससे बेहतर कर सकते हैं ना. So these words really are important, and they reassure the patient and the family that we understand them. Then environmental modifications, which I said, reorientation techniques or memory clues such as a calendar, clock, family photos, they may be helpful. The environment should be stable, quiet, well lighted. Support from a familiar nurse or family should be encouraged, right? So not too cold, not too warm, well lighted room is important. Family members and staff should explain proceedings at every opportunity, reinforce orientation, reassure the patient. Sensory deficits should be corrected, like if the patients use spectacles or hearing aids, so that must always be available with the patient. Then we come to drug treatment. Drug treatment, commonly the haloperidol, mirtazapine, quetiapine. IV may haloperidol most commonly used. If the patients can take orally, mirtazapine, quetiapine, these are commonly used medications. And review and review. So always keep reviewing the patient's charts as to what are the medications, if any medication is causing, if there's any withdrawal, any electrolyte disturbances, disease progression. All these things must be kept in mind. We cannot start every patient who has become delirious on haloperidol. So review the charts. It's very important. To summarize, it is delirium is underdiagnosed, misdiagnosed, screen for it. It does, when happening near end of life, it does, tell us that it's a poor prognostic sign, but do correct the correctables. Non-drug treatments, very important. We cannot really, we really have to emphasize it, to emphasize non-drug treatments in our practice. And drug treatments, of course, are important. Many times we have to take those things. Yeah, majorly, yeah, that's it. Thank you from my side. I am very happy to take questions. I hearing impairment or patients who are mute. So, or yeah, mentally impaired, of course, that would be one separate thing. But who are just hearing impaired, or if they are mute, family members can really help us, understand their baseline state. And if there is a change in that baseline state, I think family would really help us, even in mentally impaired patients. Family members would be able to help us, to identify, I think, and to conduct some screening programs, screening, maybe to use MMSE for them, for such patients.
Thank you, Dr. Megha. Are there any other questions or sharing your experience? Like, how do you manage delirium in your all setting?
Should I stop sharing, huh?
Yes, yes. Please.
So I can see it.
How do you manage delirium in your settings? How common do you come across patients with delirium? Not just terminal delirium, or maybe there are people working in ICUs here. How common it is?
Shri, your voice, मैं अपना volume कुछ बढ़ाऊं क्या? एक second, मेरे को बहुत कम आवाज आ रही है.
And if it is too low, I can connect to my earphone. I'm not using an earphone. Maybe that's why.
No. I can hear it better now. मेरा volume कम था इसका system का. हाँ.
So we would like to hear from you your experience in managing this symptom, how common it is in your setting, and is the management strategy similar to what Dr. Megha was discussing till now? I'll just wait for your responses.
Whose responses are you asking me?
No, from the participants, like how often do they come across such symptom and how do you manage? Is there anything different that they do that we can hear about it? Dr. Ranveer, I think there is one more device in your room. Probably that's why it's echoing. Can you try speaking now? Anyone else in the chat or unmuting?
Uh, am I audible here?
Yes, Dr. Andrew, please.
Okay, I would like the opinion of our instructor today, and I would like to share my experience. In my practice, I see a lot of alcohol withdrawal, a lot of alcohol dependence syndrome. And of course, we see a lot of delirium withdrawals, everything classical which is related to alcohol withdrawal, some of which have been taking alcohol for a decade or so. My question is, we use we use benzodiazepines, haloperidol also, but according to my experience, when we use Ativan, I'm not sure whether it's at 1 milligram or 2 milligram, but sometimes we get, I don't know, is it a resurgence of withdrawal with lorazepam? What does your experience say about this? I mean, is there a subset where lorazepam, that is Ativan, does not work, or refractory, or increases the symptoms of withdrawal? I mean, I would just like to uh, share my view, and can you please advise me what to do?
Mhm. So, Dr. Andrew, I don't think all benzodiazepines, although they are not the first line drugs for management of delirium per se, but yes, many times we need to use if there is associated anxiety along with delirium. But in my experience or any studies that I have read recently, I have not found any difference in different benzodiazepines that we use, lorazepam or others, clonazepam. That's my perspective to it.
Okay, thank you.
Thank you,
So,
Dr. Andrew, and thank you.
in chat, there is
Yeah.
in ICU setting, hyponatremia is a common entity leading to delirium. By correcting it, we can, yes, absolutely. Hyponatremia is an important cause. Yes. Thank you, Dr. Urmila.
And I think many a times this can be controlled even without starting the haloperidol. Just correcting the correctable will usually fix the issues in delirium.
Absolutely, yes.
If there are no more questions, we can start the case presentation. I think we finished a little early, but we can start the case presentation and take discussion later.
Absolutely. Let's do.
Dr. Urmila?
Am I audible?
Dr. Urmila. Yes.
Am I audible? Hello? Hello?
Yes, Dr. Urmila, we can hear you.
Okay, thank you. Good afternoon. Thank you, Dr. Megha, for your very elaborative presentation and giving us knowledge on this topic.
Dr. Urmila, your voice is not very audible. I mean, we can hear it. Is it only for me or everybody? I mean, maybe can we have an increase in volume? Maybe.
Hello? Hello?
Yes, ma'am.
Now? It's audible?
Yes, now it is better.
Hello? Hello?
Yes,
It's audible now?
yes, ma'am, it's audible now.
Good afternoon. Thank you, Dr. Megha. Today I am presenting a case of delirium. It's a follow-through case of intestinal obstruction operated for exploratory laparotomy with ideal resection and anastomosis. Next, please. This was a 65-year-old male presented with a pain abdomen for 5 days, multiple bouts of vomiting 2 days, and unable to pass feces and platters for the past 1 day. He didn't have any significant past history other than he was a chronic smoker and chronic alcoholic person. And he used to live with his wife and 3 sons, and financial condition was not good. Preoperative findings on examination was almost okay, except that general condition. On general condition, he was looked unwell and lethargic. And on investigation-wise, he was almost within normal limit, except that this creatinine was 1.2, keeping in mind his age, advanced age 65. And on X-ray, there were multiple air fluid levels. On the basis of history and examination and on these investigations, the diagnosis of intestinal obstruction was made. So he was planned for laparotomy with ileal resection and osmosis under general anesthesia and epidural analgesia. The whole period was remained uneventful, but considering his advanced age and the underlying pathology, he was shifted to ICU for post-operative care. And he was kept on post-surgical treatment, and he was kept ill for 3 days. He was doing well, but on third day, he started becoming agitated and in all his IV cannulas, Foley's catheter, and he started abusing his relatives too. Next, please. On examination, patient was appeared to be confused, irritable, and with fluctuating attention level. He was disoriented and was not recognizing his relatives. So psychiatric reference was done and diagnosis of alcohol withdrawal was made. So he was started with injection multivitamin, oxygen and chlordiazepoxide, benzodiazepine subgroup of drugs, and olanzapine, that is neurolaptics. And with the course of with the passage of time, over a course of 5 days, he started showing the signs of improvement. So his benzodiazepines and his neuroleptics were stopped. He was also prescribed topiramate for to stop the cravings. And after 3 days, patient was shifted to the ward. So the diagnosis of delirium was made because exactly the cause of delirium is unknown, but it is said to be multifactorial. And in my patient, there's a history of alcohol dependence along with the surgery he has undergone and the pain and antibiotics he was kept on, and immobilization and separation from his loved ones and confinement to the ICU for long periods of NPO, long ICU stay. That led to the development of delirium in my patient. So my case scenario is a 65-year-old male, chronic smoker, alcoholic, operated for laparotomy with ileal resection and osmosis for intestinal obstruction. My point of considerations are: what is delirium? How does it occur? And what is the association between delirium and palliative care? And what will be the effect of this delirium on the family members? Thank you.
Thank you, Dr. Urmila. I think the first two questions might be, answered most of the questions, but there is one chat also from Dr. Mrinal. How can we differentiate delirium in a long stay ICU patient and old age patient? Is there a classical symptoms that we see to diagnose patient is having delirium?
So I think Dr. Mrinal, regular screening for delirium is very important, especially in the patients who are at higher risk, where there are these precipitating factors like, patient has been shifted from change in environment and the other precipitating factors that we discussed. So I think regular screening will help us, identify these patients identify them early for delirium. So it can be, it will be different from institution to institution. You can use a simple scale like MMSE, or just talking regularly, getting to know about their orientation, about ICU patients, or even in old age, and making either we use some standard scales. I think that is the actually the best way to do it, screening them regularly with MMSE or a scale like that, or otherwise I think just incorporating these questions in your daily rounds and daily interviews with the patient. Could I answer your question, or are you still Not sure about it. So the question was, is there any classical symptoms that we can see to diagnose them? So I think classical symptoms are there again, you know, many times, especially in old age, hypoactive delirium is again very common. They become withdrawn and they do not want to talk. So, but there are, I don't think there are any classical symptoms that, you know, will direct us. Talking to them and asking them the similar things would help. Do you want to add something, Dr. Shri?
No, Megha, you have answered that question well. I hope, Dr. Mrinal, is there anything else that you are looking for, or was the question answered? And to Dr. Urmila's question, Megha, would you like to take up that?
Yeah, sure. So, what is delirium? I think we took that. Would you like me to repeat it, Dr. Urmila?
I think maybe a few points on.
Yeah. Just so I think whenever we talk about delirium, as I already mentioned, 4 important things. Okay, change in consciousness, change in cognition. It's an acute thing, and there's an underlying cause. That is what delirium is all about. How does it occur? There can be many causes to it, right? That we already discussed. And I think the third question, which is association between delirium and palliative care, very important, because all these the risk factors that, you know, we talked about, that many patients are old, many patients have had you know, change in the many patients, you know, they are at high risk, they are on opioids, they are on cholinergic medications, then you know, they are many of our patients in palliative care are at higher risk of developing delirium. Then there is also a change, many times there are many precipitating factors whenever patients you know, the patients, they come to hospital for management of their symptoms, and or sometimes they have to be shifted to ICU if there is an acute episode or something. So I think delirium and palliative care are very closely related, especially you know, near end of life. As we said, it's and it is also a poor prognostic indicator. When the patients start becoming delirious, they it's a poor prognostic sign for us in palliative care. And so the fourth question, what will be the effect of this on family members? As we mentioned, you know, it's very distressing for the family members when the patients do not act themselves, or if they start having hallucinations or delusions. So it's really difficult for them to take their loved one like that. However, telling them that this is not madness, as we earlier said, in as a first principle of non-pharmacological management of delirium, and telling them that, you know, we correcting the correctable if we can. So find out the cause, correct the cause. That will help, and of course, being there, lending a listening ear to the family members goes a long way. That how they are feeling, what they think the patient was, and now how has the, and understanding the baseline status of the patient is again very important, and family members can help us in that. So yes, I think it does have a deep impact when the patients become delirious on family members, and we need to take care of them. We need to tell them that this this happens, you know, when patients are nearing end of life, and we are trying to correct all the correctable causes for it. Dr. Umesh says that the family counseling also important. Yes, I agree, Dr. Umesh. It's purely a clinical diagnosis on the basis of history, examination, investigations. Thank you, Dr. Urmila. Yeah. Dr. Mrinal, you want to say something?
I think it was accidentally unmuted. Any other questions regarding delirium, its management, or anything that we have not touched upon? Please feel free to ask.
or any other experience that you would like to share?
Parul is asking, is in this case, is there anything that could have been done to prevent delirium?
I feel, maybe letting family to be inside a little more than less often could have helped. The ICU nurses, they can help in orientation protocol with the patient. That helps. And maybe the patient has had some electrolyte disturbances while he was NPO. So taking care of those electrolyte disturbances, I think, could have helped. And yeah, being more empathetic by the ICU team could have helped.
Is there any time specific timeline to call it as delirium or to rule out?
Sometimes.
Dr. Roshan is asking that question.
Yes. Is there any specific timeline to call it as delirium or to rule it out? No, I know. I don't think it is just a change from the baseline. It's an acute change from the baseline. I don't think not in any of the criterias that I read about exact timeline, like is it 1 day or 2 day or hours. Are you aware of it, Dr. Shri?
No, it's generally an acute change that we notice, and I think that answers the next question also, Dr. Sangeeta, how to differentiate between delirium and senile dementia. Dementia will be slow onset, chronic onset, and the delirium will be an acute onset. A delirium just starts all of a sudden. They might tell you patient was all right till now she started talking in the sleep. Or and to Dr. Parul's question on the prevention part of it, yes, as Megha mentioned, there are certain things like orientation and time, familiar faces, many things can be done, but many things which are not avoidable, like some things like ICU admission may not be avoidable all the time. uh, and identifying if in palliative care setting, identifying whether they have hypoactive delirium also plays a major role. Sometimes we think that the patient is depressed, that's why they are not talking. So if you identify, they say hypoactive patients with hypoactive delirium are more likely to get terminal agitation because it goes unidentified. The other part, hyperactive, we identify much more easier because they are too noisy or creating a lot of confusions. It's very important to pick up on the hypoactive delirium and start treatment early. And as Dr. Umesh, I think, was mentioning about the caregiver training, very, very important, because as I said in the beginning during intro, caregivers go through the most of the distress because they have to, they see a whole different person one fine day. So we usually come across people using abusive words, which they might not have used in their entire life, and then they start beating up their partners or start abusing the healthcare workers. And the wife usually tells that he had never used these kind of words in his lifetime and we've never seen this. And then obviously removing all the clothes and then walking around naked. So all this will affect their dignity, and the caregivers are very, very distressed seeing this. When someone comes seeing their loved one in this, they may not encourage visitors because this is how they are going to be presented. So that's a very distressing situation. And if you have an elderly person and the wife is also elderly, going through all this, like she herself will be dealing with a lot and seeing this, and how much ever you counsel, they have a tendency to keep correcting the person. No, it's not night. No, you had idli in the morning. Why, how did you forget? I remember I fed you. So they take it very personally. See, this guy is lying. I've fed everything or I've done everything. So the lot of interpersonal issues happens at that time. That's what we have seen. When the caregivers start crying, now see how much I have looked after him, but then now he's abusing me a lot. So caregiver needs a lot of support, and sometimes patients after some time they say, I knew that something has happened and I did something wrong. Some people actually recollect many incidents that happen. So all this will be very traumatic for the patient and the family. So it's very important to, and unfortunately, all the reviews says that this drug is not, nothing is conclusive in terms of medical management. You can't say this is the best drug or you cannot use this, you should use that. Every evidence in terms of medications are inconclusive, but general guideline is to start with an antipsychotic, not completely depending on benzodiazepines. But I think, as Dr. Andrew was telling, benzodiazepines works well many a times. So it's all about starting with an antipsychotic, then adding a benzodiazepine will be the better way to go about it, although the guidelines are not really clear about it. Dr. Kalindi is asking how to manage delirious patients at home, like the ones with progressive brain tumors or brain metastasis.
So I think in those patients, medical management would be important. Identifying if it's hyperactive or hypoactive, especially if it is hyperactive. In those patients, it's very important to prescribe IV or oral antipsychotic agents. And they are, or maybe as Dr. Sri just mentioned, addition of some benzodiazepines may also help. So yes, I think that it will be important to have medical management drugs. Yeah.
Yes, Dr. Prakar is mentioning that in ICU settings, midazolam infusions has been shown to increase delirium. I totally agree, Dr. Prakar. We just don't recommend benzodiazepines as the first line. Suddenly, it just aggravates. But it is the most commonly used drug, I think, in many of the settings. People start with benzodiazepines and thinking that the patient will sleep. But many a times it exaggerates delirium. But with baseline antipsychotic, midazolam infusions work like wonders. So we give haloperidol infusion or intermittent subcutaneous injections. If terminal delirium, it's usually haloperidol infusion along with midazolam infusion. That combination works better than giving benzodiazepines alone. And in home-based setting, sometimes our most of our patients die at home, and many of them have delirium. So we try to educate the caregivers to give subcutaneous injections at home of midazolam if they are capable enough. We try to teach them. We put the subcutaneous line and give the loaded syringes and tell them to give whenever the patient or whatever the haloperidol that we are prescribing. Not for everyone, but for many patients that has worked, giving the subcutaneous injections and training the family members to give the injection at home. Any questions that I missed from the chat?
No, I think we covered everything.
Yeah, I think Dr. Urmila has mentioned delirium may complicate the underlying dementia. Very true. And sometimes the medications that we give for delirium can cause more rigidity and other issues for some patients. Dr. Parul is asking the role of quetiapine.
Patient transdermal lorazepam can be around transdermal patch of lorazepam. I'm not sure.
I have not used, Dr. Urmila. I have not heard also. We use sublingual at home. Sublingual tablets are available.
Yes,
That is commonly used in a home care setting. Even if the patient is end of life care, we tell the caregivers to put it under the tongue, or midazolam or loaded midazolam syringes we do give for subcutaneous injections at home. Midazolam nasal sprays are available, but the dosage is meant for pediatric use. So you will get 0.5 dosages per spray. So you may have to use more sprays.
And the action is also very short, for midazolam. So yeah.
Yeah, I have not used. I have not heard also about lorazepam patches.
Me too.
That would be wonderful if they have lorazepam patches, because it's easier to give in a home care setting.
But again, with patches, I don't know, because they are usually more. The duration of action is more prolonged. So how long to prescribe, and because mostly doses we need to increase or decrease in between. the doses, required doses may not be constant, you know, so use of patches, I'm not sure even if they're available, how much we'll be able to use them. That's one thing.
Role of quetiapine, would you like to comment, Megha, in delirium?
Yeah, so quetiapine is a great oral antipsychotic, just that it's not available IV. If the patient is able to take orally, we can start the patient on quetiapine. Many patients, in fact, it is one of the safe ones. We use it regularly. However, again, I think in this also, both with haloperidol and quetiapine, you know, ideally we should have a baseline ECG, see the QT intervals. They are both known to prolong QT intervals. So just that. Otherwise, quetiapine is a good medication. We can use it.
We also use quetiapine, especially when there are a lot of sleep disturbance along with delirium. We start with a smaller dose because sometimes people, even with smaller dose, they sleep.
They sleep a lot.
Through the day.
Yes.
So, and the advantage is that you can go a little higher with quetiapine. Psychiatrists go much higher with quetiapine, although we don't go that higher. But we do use that a lot, especially when there is a associated sleep problem also at night and day they are not sleeping at all. Then quetiapine we do use. I think there are no more questions in the chat. We finished much early today. Usually we finish by 4:30. Thank you so much, Dr. Megha, for answering all the questions and sharing your presentation with all of us. Thank you so much, participants, also for bringing up the questions, and Dr. Urmila for the case presentation so that we could have some discussion and learning from that. Thank you so much, everyone, once again, and see you for another interesting topic the next day. Thank you.
Thank you so much, Sri. Thanks. Bye, everyone.